Okay, let's get started. I'm very happy to welcome you to a virtual event by the Petrie-Flom Center. I'm Glenn Cohen. I'm a professor at Harvard Law School, an expert on health law and bioethics, and I'm also the faculty director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics. We are still experimenting with the Zoom format, so hopefully this will go smoothly, but we ask that you bear with us for any technical glitches. So before I talk a little bit about the content today, just a few ancillary announcements. First of all, I want to let you know that starting today on the Petrie-Flom website, we are launching our COVID-19 resource page. It'll collect all of our scholarship, commentary, and events on COVID-19, along with a top 10 list of our most relevant and helpful materials. It'll be available under the resource tab. Also want to let you know to put on your calendar that on April 22nd at noon, we're hosting Ethical Dilemmas in Mask and Equipment Shortages, looking at the shifting standards around PPE best practices, the duty of providers to take care of patients, the duty of institutions to provide safe workspaces for healthcare workers, and the structural forces behind all the PPE shortages, and reflections from frontline emergency department nurses at a COVID-19 hospital. And you can register for that event on our website. For any Harvard 1Ls, 2Ls, 3Ls graduate students, our call for the 2020 to 2021 Student Fellow application is now posted online. Please reach out to myself or to others if you have questions, but we're excited to welcome another class of Student Fellows in the coming year. Okay, now on to the main event. This event is in support of our forthcoming book, Disability, Health Law, and Bioethics, which will be published this month by Cambridge University Press. The book came out of our 2018 annual conference exploring the framing of disability and the impact that this framing has on medical and legal policies. And you can find information on how to order the book on our website. We also, though, want to recognize the efforts of our co-editor, Anita Silvers, who sadly passed away last year. Anita was an amazing scholar and a wonderful colleague. We were just so lucky to have her to guide this book as one of her last projects, and we miss her very, very much. For this event, we're not going to be taking questions through Zoom. Instead, we're going to be pulling questions from our Twitter feed. So if you've got a question, and I hope you will, you can tweet it at #DisabilityCovidTriage. Once again, #DisabilityCovid, C-O-V-I-D, triage, all one word. And we'll be monitoring that hashtag and pulling questions to ask all of our panelists. Unfortunately, we're not able to provide live captioning for the event, but we'll be posting a version of this event complete with captions within 1 to 2 weeks. It'll be freely accessible. Okay, now let me introduce our amazing panel. I've instructed them all to speak for no more than 12 minutes, and unfortunately, if they go over, we will interrupt them. They've been told this, so just to warn you. First, we're going to have Govind Prasad, who's an author of a chapter in the book. He's an assistant professor at the Stern College of Law, University of Denver, and a Greenwald Foundation faculty scholar in bioethics. After him will be Leslie Francis, also an author chapter in the book. She's the Alfred C. Emery Endowed Professor and Distinguished Professor in the College of Law, Distinguished Professor of Philosophy, and Adjunct Professor in Family and Preventative Medicine, Internal Medicine, and Political Science, a lot of departments, Leslie, at the University of Utah. Then we have Michael Ashley Stein, a co-editor of the book and also a chapter author. He's the co-founder and executive director of Harvard Law School's Project on Disability and a visiting professor at Harvard Law School. Finally, we've got Omar Sultan Haq, who's a chapter author. He's a faculty member in the Department of Global Health and Social Medicine and the program in Psychiatry and the Law at Harvard Medical School, and the co-director of UNESCO's Chair in Bioethics American Unit. They're each going to speak, and then I will convene us back together for questions, including questions from you, the audience, on Twitter. And with that, Govind, I'm going to let you take it away from us.
Great. Thank you. Thanks, Glenn, and thanks to everybody here for joining us and to the Petrie-Flom staff for all of their work. Before I get into the legal and ethical issues I'm going to talk about today, I want to make a couple of just more general comments. The first one is that this coronavirus situation makes me angry and makes me scared and makes me sad. And I'm suspecting a lot of you feel the same way as I do. I'm angry because I don't want it to be relevant which of two patients gets a ventilator. I want to be here in Denver watching other people like Michael, like Glenn, like Omar live in Cambridge talking about issues in disability that are inescapably relevant. And what the New York Times has reported, say, about the federal response shows that this didn't need to be this way, that it could still be better if we had competent people in charge on the federal level. I'm scared because I'm scared that my 1.5-year-old isn't going to get to see his grandparents, some of whom have disabilities, again. I'm scared for them, and I'm scared for him. And I'm sad because people are dying. We probably all have different things we read that make us sad or upset when we see this. Seeing the headlines about the 11 pages of obituaries in the Boston Globe. I was reading 2 nights ago about a woman in Michigan whose husband and her only son both died 3 days apart of coronavirus. And so if I might sound more emotional sometimes about some of this than might be expected from this time of talk, that's why. So with that said, I'm going to try to start with some slides that frame the legal and ethical issues, and then I'm going to turn to talking about law and about advocacy. So I'm going to share my screen now to share some slides here. So the first slide here on the left side, this is a slide that tries to separate the criteria that I think are legal in pandemic triage from the criteria that are not legal. So on the left side, I think the criteria that are legal would include considering evidence-based decisions about a patient's probability of surviving treatment, evidence-based predictions about the quantity of resources used, and evidence-based predictions about short-term life expectancy. And this isn't just my view, it's also based on the view of Wendy Hensel and Leslie Wolf in an excellent piece they wrote for PLOS Currents. They're currently the, I think, interim dean and provost at Georgia State. Some people disagree with this slide. For instance, Senator Warren just signed a letter saying that relative probabilities of surviving treatment shouldn't matter unless the probability is tiny. And something that I'll call minimal triage for now, Professor Francis and I will talk about this, that Sam Bagenstos, Ari Neiman, and others endorse, wouldn't allow considering how long somebody's expected to be on a ventilator, even with evidence, or whether you're likely to survive for 1 or 5 years beyond hospital discharge. I think these positions misread the law. I think they're not ethical. So as an example, consider cancer. Late-stage pancreatic cancer, this is a terrible disease. It has a 3% 5-year survival rate. That means 97 out of 100 die in 5 years. That should matter. A condition like late-stage pancreatic cancer is really different from other disabilities, really different from something like deafness or chronic pain. And disability law shouldn't treat those conditions, deafness and late-stage pancreatic cancer, the same way. I highlighted in yellow here 2 areas where I think law and ethics may come apart. I think law permits consideration of even longer-term life expectancy, but there are good ethical reasons to worry about long-term life expectancy being shaped by social injustice, and that relates to issues I talk about in my chapter for the book. I think the law probably prohibits considering quality of life, or at least prohibits considering what are called quality-adjusted life years, but we may discuss rare cases where that would be ethical to consider. Professor Nirayal's chapter in this book is about this, and Leslie and I may talk about that as well. And then, of course, on the right side, some of the areas that I think are clearly not legal and not ethical would be evidence-supported arbitrary determinations or discriminatory animus, decisions motivated by dislike or fear of people with disabilities, the sort of thing that the Supreme Court talks about and condemns in a famous case called Claiborne versus Cleveland Living Center. So I'll go now to my second slide here. So this next slide tries to respond to people who say, well, saving more lives, that's just efficiency, that's just utilitarianism. I don't think that's right. I don't think saving more lives requires saying something like that people with disabilities are in any way less worth saving. And these quotes up here are from 2 really well-known ethicists who spent a long time, actually, as it happens, in Cambridge. The top left is from the philosopher Derek Parfit, who passed away, I think, a couple of years ago. The bottom right quote is from Frances Cam, who some of you may have taken classes with. She was for many years at the Kennedy School and is now at Rutgers. And the idea behind both of these is that if we give equal weight to saving each person, we should try to save more lives. And I think that's a goal that goes through COVID response. doing something like postponing surgeries, that's really bad for some people, but it saves more lives overall. So I'll go to another slide now. This is about why I think duration of use, how long somebody is predicted to be on a ventilator, can matter. You might be able to save 4 people with a ventilator over 4 weeks, or save only 1. You might be wondering why somebody is in a blue box on this side. This is because among the 4 people you save, a quarter of people in the US have disabilities. So when you're saving more people, you're also likely to be saving more people with other disabilities, disabilities that don't affect probability of surviving on ventilation, disabilities like deafness that I mentioned before. So I'll go now to my next slide, which is about why probability of survival matters. Here again, if you look at this slide, look on the left side, if you're looking at 4 people with a 75% probability of survival, if you consider probability of survival when allocating ventilators, you're likely to save 3 people as opposed to predicting to save only 1 if you save with the probabilities as they are on the right side. This is about relative probabilities. If you change this to a 30% versus 10% probability of survival, the same thing applies. I didn't have room on the slide for 10 people. The same sort of reasoning applies. It's going to be important to distinguish concerns that we might have about how to fairly predict probability of survival from the argument that probability of survival, number of lives saved, doesn't matter. My objection is to the latter argument. I suspect that there are ways that we can improve, make more fair or probability of survival judgments, but I don't think we should throw out the relevance of that concept and throw out the relevance of saving more lives. So I'm going to turn now and stop my screen share and go back to some comments about law and advocacy. So if you all are able to stop the share, actually I'll just do that here, that would be great. Why are the criteria that I argued are ethical to consider, probability of survival, short-term life expectancy, why are those not only ethical but legal to consider? A couple of points here. The first one is if we think about lung allocation, when we allocate another scarce resource, lungs here, we do look at probability of survival and at short-term life expectancy. And those are considered to be legal when allocating scarce lungs to patients in need. The second is case law. So even when we apply the ADA to medical decisions, the few cases that do apply the ADA in medical contexts, what they do is they strike down groundless judgments. They say, you can't make a decision on the basis that one of them is about a doctor who said, oh, all deaf patients are high risk. I won't treat pregnant women with deafness the same as others. The ADA upholds factually grounded predictions, and even when there are disputes about those predictions. And the case law says also that the ADA does not entitle each patient to the level of health care precisely tailored to their particular needs. It allows considering how a policy would affect other people. And it doesn't require accommodations that burden other individuals, as opposed to the sorts of accommodations we're more familiar with that may require businesses to spend money. Now I'll turn to some comments about disability advocacy rather than law. And they connect with law, but I think they go beyond law. The first is that, so people with disabilities often have interests that align in advocacy, but here I think at least they potentially conflict. Because the vast majority of disabilities, hearing, sight, intellectual disabilities, they don't affect whether you'll survive being on a ventilator or how many resources you'll use if you get COVID-19. Most people with disabilities don't have late-stage lung cancer. They don't have severe emphysema. Some people have argued triage is still unacceptable, even if it saves more people with disabilities, because people with disabilities, they say, need to be in solidarity. This is an argument that makes me mad. The goal of disability law should be to help people with disabilities and to avoid stereotyping. It shouldn't be to mandate solidarity. So Sam Bagenstos, who doesn't make the solidarity argument, he says, look, not hiring a blind bus driver, that's a case where it's legitimate to consider a disability. Solidarity doesn't mean that a disability with a driver with a psychological disability or with chronic pain should be banned from driving the bus just because a blind driver rightly is. Solidarity means the blind driver should be supported in getting a different type of job that wouldn't be limited by their disability. If the government doesn't provide that support and other people with disabilities want to protest, that's fine, but they shouldn't be forced into solidarity. The same thing is true for ventilators. The goal should be to protect somebody who doesn't have a good chance of survival from getting coronavirus. We should be trying to protect, say, people in assisted living facilities. We shouldn't be trying to require doctors to ignore differences in prospects if people do get coronavirus. Some people also say, oh, I'm okay with banning triage, going first come, first serve, going into lottery, even if it costs more lives. I'm not okay with that. The proposals I'm seeing from some disability groups would cost the lives of many people with disabilities because they would mandate that states and hospitals ignore differences among people with disabilities. This is the opposite of what disability law, I think, should be doing. Saving more lives among people with disabilities, even if it creates some inequality between people with different disabilities, that's more important than restricting the use of medical evidence so that we can ensure that everybody has an equal but higher chance of dying irrespective of their specific disability. I think it's more important to save more lives of people with disabilities. I also think it's important for advocacy not to prioritize visible over invisible people. People who think they'll get lower priority under triage, they can offer personal stories. People who will lose their lives under random selection, under a lottery, they're likely not aware of that. They're not able to respond to these kinds of personal stories. I worry that getting rid of evidence-based triage would harm most disabled people, even if it would protect a few who are more visible. The last thing I want to say is that it bothers me to see advocacy inviting the same federal officials at HHS who killed people by mismanaging the initial response to COVID-19 to now set policy about how other people respond to scarcity that they produce. HHS says in their statement about discrimination that they leave no one behind. I don't think advocates should take that at face value. The way HHS has managed things has left a lot of people behind, has left some of those people who were left behind dead. Instead of advocating for HHS to make these rules, I would love to see disability advocacy, and I've seen this happening, work to support evidence-based guidelines that are responsive to public input, like the Maryland, like the New Jersey guidelines, and to work to make sure these guidelines are free of bias, free of unsupported assumptions about disabled patients. So that closes my comments. Thank you all so much for your time, and I'm looking forward to your questions and to my other panelists.
So let me start by thanking Govind, because I'm going to be critical of some of what he says, and also thanking everyone at the Petrie-Flom and everyone listening for really raising these enormously difficult and truly tragic issues. So in my talk, I'm going to focus on 3 points. First, why I think Govind's analysis is wrong about whether proposals that would triage minimally, that is, let near-term survival count, but not anything else, are problematic from the perspective of equality. Second, why the maximize lives saved approach arguably does violate the ADA. And to make this argument, I'm going to use a distinction between modifications and accommodations that Anita Silvers, who I regret so much is not here, that Anita and I developed in our contribution to this volume and in some other writing. And finally, I'm going to look at how an understanding of the difference between accommodations and modifications can be deployed for accommodations of healthcare workers, which is another issue we shouldn't forget. So minimal triage says that in prioritization decisions, we may only consider the short-term likelihood of surviving COVID-19 itself, along with the probability of surviving very near-term life-limiting illnesses. Parenthetically, I would suggest that there probably are not very many patients who have good short-term survival prospects and good prospects of surviving COVID-19. I would guess that if you have poor short-term survival prospects, you also have a poor chance of surviving COVID-19. Govind says that equality requires maximizing lives saved because this would maximize the percentage within the population of people needing ventilators who get saved. This aggregates people into an overall figure of lives saved. It doesn't increase the probability of any individual's life being saved, just the probability of lives saved across the collective. Another model of equality disaggregates, considering equally each person's chance of being saved. This is the model I favor ethically as respecting each as an individual. That is, you can't infer from the aggregate that we give each person within the aggregate chance of being saved. So Govan doesn't, I think, have the high ground on equality. Now to the law. Alexander v. Choate, decided by the court under the Rehabilitation Act in 1985, 35 years ago, considered Tennessee's decision to limit its Medicaid patients to 14 paid hospital days per year, no matter their conditions or whether they would need 15 days to get well. And as Tennessee had a policy that was like, you only get so many days on the vent. The court said that policies with a disparate impact on people with disabilities could violate the Rehabilitation Act, but that this policy didn't. That's like saying life years saved policies don't violate the ADA, even though they have a predictably different impact on older people. The decision has been taken to stand for what's called the access benefit distinction, that states are free to define the benefit, like life years saved, and don't discriminate if they give people access to the same benefit, 14 days in the hospital or so many days on the vent, according to the life years saved protocol. However, this conclusion is too quick about Alexander v. Choate and disability law more generally. One problem made with Alexander v. Choate, which I'm going to skip over briefly, was that the plaintiffs in the court below made a very problematic record. They didn't do a good job of actually showing disparate impact here. But the problem I want to focus on was that Alexander v. Choate magnified a mistake in an earlier case, Southeastern Community College against Davis, that confused accommodations with modifications. Let me explain. Accommodations, which is what Govan was talking about, are individualized alterations that enable people to participate in activities, employment, programs, and so on. People who are capable of such participation with the accommodation. Familiar examples of accommodations are ergonomic keyboards, screen readers, or sign interpretation. Think of them as equipment that enables individuals to exercise their particular capabilities. Modifications change world or policy designs that have functioned to exclude in ways that can be changed without fundamentally altering activities or being unduly burdensome. Modifications potentially benefit each of us. Think of curb cuts, ramps, or telecommuting options. Accommodations gone too far are subject to the objection that they give individuals receiving them an unfair advantage, like you get to survive no matter how much you pig and others don't. Modifications are subject to the concern that they are unreasonably burdensome, but not that they unjustly bend the rules for some, but not for others. Now, there was a problematic earlier case that gave rise to Alexander v. Choate, Southeastern Community College versus Davis. In that case, a potential nursing student with hearing loss sought accommodations, such as placing instructors so that she would be able to lip read what they were saying. The college instead construed her as asking for the admittedly unreasonable modification of the nursing program to eliminate all clinical training and graduate her as a nurse. Davis was decided the same year the Supreme Court rejected affirmative action in Bakke, and the court misconstrued Davis's request for affirmative relief as a request for unjust affirmative action that would allow an unqualified person to enter nursing. Alexander v. Choate compounded this error. Here, the plaintiffs asked whether there were other ways to design Medicaid cutbacks than a straight 14-day cutoff that would achieve similar fiscal goals without as great an impact on people with disabilities. They asked, that is, for a modification. But the court stated that they were asking for individual accommodations that were unjust affirmative action, guaranteeing each all the medical care they needed in preference to others. Although he didn't use the words affirmative action, this is how Govin's analysis of the law framed the disability critique that we're hearing today. There's potential for exactly the same mistake in the ventilator protocol discussions. Disability rights activists are not asking for individual privileging that would give them rights to survive over others. They are asking for evidence-based protocols that use individualized assessments of survival prospects similar to those of others without disabilities who are using ventilators. This may require modifications of ventilator allocation rules that would limit the number of days on the vent, for example. So if we think about what's being requested as modifications, we can think about the kind of individualized equality design that I suggested, rather than thinking about particularized accommodations that would be tailored to maximize any given individual's right to survival. Now let me turn to apply this analysis to healthcare workers very briefly. Many healthcare workers have conditions that would place them at greater risk from COVID-19 than their fellow workers, or they have family members with such conditions. What accommodations are reasonable under such circumstances? For example, would it be a reasonable accommodation to allocate the highest risk procedures, like resuscitation attempts, to others without those conditions? Maybe not, because of the burdens that would be placed on others performing the function. But if there are risks to family members, perhaps paying for a hotel in which the worker can isolate from family would be a reasonable accommodation. Another accommodation question is whether these functions are essential job functions that individuals must perform in order to be considered qualified for their jobs. We need serious thinking about these questions about accommodations that shouldn't be lost in the very high-profile questions about ventilators, including whether we should be considering them through the frame of accommodations at all, rather than through thinking about what tragic circumstances require about modifying job responsibilities for everyone. Perhaps a reasonable modification in the worst of circumstances where personal protective equipment is limited is the decision not to perform highly risky resuscitations in cases where prospects for success are bleak. Thinking about the distinction between accommodations and modifications for healthcare workers, I conclude presses questions that we really ought to have been thinking about for everyone. How can we create the best protection we can in the most just way under our current circumstances of great, horrific difficulty and ongoing injustice? Thanks very much.
Thank you, Leslie, and thank you everyone for joining us. It's a pleasure to be with you, and I have another chapter that my great friend and colleague Omar will be speaking about in just a bit, so I will spend just a brief amount of time on the chapter with Matthew Smith and Tara Allison on sexual agency and intellectual disability, and then pivot over to our discussion today of COVID. The points that we make in the sexual agency chapter is that our society often uses regulations and assessments that treat persons with disabilities, in the case of this chapter, intellectual disabilities, differently by devaluating them as individuals. And we argue and show examples such as group homes requiring certificates of competency for people with intellectual disabilities, adults living on their own, to engage in volitional intimacy, whereas we would never ever consider that for the rest of the population over age 18. And as part of that chapter, we also argue that the architecture of intimacy, an idea that we take from our colleague and friend Elizabeth Emmons, is a way of restructuring the way that we perceive people with intellectual disabilities and their sexual agency. That's so much for the chapter. I'd like to pivot over to our discussion of COVID-19. And in doing so, I'll note very quickly that at the moment, New York State is reporting 3 times the death rate for persons with intellectual and other disabilities living in group homes than of the general population. And that this should remind us that back in the days of the Spanish flu, 101 years ago, Fernald Institution, which is about a 20-minute drive from where many of us are sitting, and was the US's first large-scale institution, had a rate of 8 times the average death rate for their inmates. And it's important to highlight this because in the case of COVID, one has to wonder, with all the guidance and the learning that's happening every day, what sort of accommodations are ongoing regarding persons with intellectual and other disabilities. So for example, are individuals with intellectual disabilities, if they get to see the ICU and if they get to be intubated or ventilated, are they being given instructions in easy to understand language? What is the effect on individuals who are on the autistic spectrum of isolation? These are issues that I haven't seen very much on, but ought to be raised. What we have seen, though, and perhaps too much of, is guidance by several states, prominently Alabama, that explicitly excluded persons with intellectual disabilities, dementia, and others from being eligible for ventilators and other services. That guidance has now been rescinded by the Office of Civil Rights in Washington, and thankfully so. One of the individuals who helped to precipitate that change is our friend Arin Aman, who is not joining us today in order to work on the practical side of things and who sends his regrets. But we have also seen formalized triage instructions, for example, by the University of Washington Hospital, the same ethics board that brought us the Ashley treatment, wherein a young woman with intellectual disabilities had her sexual organs removed and was placed on hormonal therapy. And under these guidance notes, people with disabilities are far, far down on the triage list. There are legal reasons touched upon both by Govind and by Leslie in different ways under the Americans with Disabilities Act and the Rehabilitation Act to believe that these are illegal, but I would actually rather focus for the minute on the politics, both when inside and outside of utilitarian schemes relating to prioritizing limited resources in the healthcare setting and specifically in COVID and with persons with various disabilities. Utilitarianism, which tries to get the greatest benefit for the greatest number, presumes that there is a limited resource amount available and then prioritizes within that amount. COVID had touched upon this and wished, as many of us do, that there were more resources available for healthcare. But this idea of Utilitarianism, being efficient, prioritizing resources, is an absolute fundamental of public health philosophy and application, and it makes sense. What are you supposed to do as far as cutting up the pie? How does one cut up an existing pie? So I'd like to talk about the politics within utilitarianism, how we cut up the pie, and then I'd like to talk about the politics outside of and detached from utilitarianism, which is how much of a pie do we have? Within the utilitarian schemes, economists recognize that economic efficiency and other efficient outcomes sometimes are invalid from a social point of view. In other words, they may make sense from a dollars and cents point of view, they may make sense from a limited resources of energy and staff power point of view, but we decide as a society that we are not going to uphold those efficiency arguments. A fun example would be the closing down of racist cafes in the days of segregation in racist states where the businesses would clearly lose money. And yet, even before Title VII, we held that those were socially invalid preferences. We're not going to uphold them. In a more economically, empirically evidence-based argument, and it went before the Supreme Court, we know that women cost more than men as far as their pension schemes. That's because women live longer. And yet, companies and others cannot discount the pension rates of women, even though they will ultimately cost more, because that is considered a socially invalid preference. We as a society push to the side socially invalid preferences for nearly every identity group except for persons with disabilities. Beginning in the 1990s, when we adopted DALYs, disability adjusted life years, rather than QALYs, quality adjusted life years, we determined in an empirically neutral, and I put that word in quotation marks, way that people with disabilities and their lives are worth less and cost more than people from the mainstream population. There are two problems with this. The first one is I wonder, since the data initially used was the early 1990s, whether it is accurate, if it ever was. The second is, even if we presume that this data and the calculus of DALYs versus QALYs is correct, why is it a socially valid scheme? Why is it that we discount and set to the side other socially other schemes that are economically viable but are socially untenable? Would we, for example, explicitly point to the fact that white individuals in this country have higher income, education, social connections, social capital, and socioeconomic status than Black persons in this country? Hence, white people ought to be able to access health care in advance of Black persons on the idea that they will have greater access to enforcing these benefits, live longer, and be able to access additional medical care and survive and flourish to a greater extent. We would never say something like this explicitly. We do implicitly use this rhetoric all the time because when people are in poverty, whatever color they happen to be, they have less access and less chance at health. But we would never say out loud that rich persons ought to be able to access health care at an advanced rate over poor persons. Although frankly, some of the things that our administration has said certainly points to that idea, as in the only individuals who have to worry about COVID, in the words of our president, are those who are elderly or not healthy. And yet here, in the case of persons with disabilities and access to healthcare, we absolutely prioritize non-disabled persons over disabled persons. I have a problem with that. Putting aside this calculus of how one divides up an existent pie, there is the point of why is it that we have the size pie that we do? And Govind touched on this a little bit in the beginning of his talk, referring to the front page of the New York Times. Resources are always limited. No country can print money to an unlimited extent, and everyone has to do with budgets and allocations. And in this sense, of course, utilitarianism is quite useful. But I would point out that how much of a resource we allocate reflects political priorities and reflects social norms and what sort of society we want to belong to. So, for example, our government has dedicated trillions of dollars to wreak havoc in the Near East, has dedicated trillions of dollars to rescue banks and overly aggressive lenders, and has done so at times when our seniors are living at a 25% poverty rate, and we have a 20% child poverty rate. Our schools are going downhill, and Social Security is teetering on the brink. Another article on the front page of the Times is, why can't we as a first-class society have a first-class healthcare system? Something that is staring us graphically in the face as we speak. To shift newspapers, the front page of the Washington Post tells us that the tax change in the coronavirus package overwhelmingly benefits millionaires. And this will be about a $90 billion package. This is at the same time that our federal government, the White House in particular, quashed a $1 billion contract for ventilators on the notion that it was too expensive. All these issues raise in dark and stark relief the question of what type of society do we want to live in? Who do we value and who do we not value? And what rhetoric do we attach to ideas of who is included and who is not included? Most of all, how do we get, if we're looking forward, from a society of us and them to a society where there's only us? Thank you very much.
Hello, thank you all for your comments. I'm going to start with first a few comments as a social scientist, and then a few comments as a philosopher. So I side with Leslie on this, that to treat people as individuals, we have to look at their unique situations and their needs, not as aggregate abstractions with equal situations that we can just subject to utility maximization. And I'm going to give a particular example of that. So imagine you have two people with the same pathophysiology, the same COVID status. One person is able to walk and another person is in a wheelchair, perhaps with paraplegia. Now, even if we believe that all people should have equal access to care, there are certain biases that distort how we estimate the likelihood of the same treatment being successful and that person surviving. So my thesis is that when viewing the disabled, we are facing, even when facing the exact same medical facts, clinicians are likely to systematically be less hopeful and too pessimistic about prognosis, treatment success, survival, and underestimate resilience. And because of these facts that are part of the real world, not the philosophical thought experiments of the utilitarian, we need to consider the unique situations of every person, not aggregating across individuals. So the first bias that's present that Michael and I talked about in our chapter is ineffectual bias. So the presumption that the disabled are lower on agency or competence, which will lead to clinical paternalism. So there's less of an emphasis on what the individual is experiencing, what their preferences are, more likely to make decisions on their behalf. You can see how this would be relevant in COVID. The second is a fragility bias. So there's a presumption that a person with disability can't handle interventions as easily. So there's going to be an increase in the perceived suffering and the severity of interventions and symptoms, and therefore resilience will be underestimated. Third, there's what's called the saintliness bias, or the presumption of being more friendly, warm, or pro-social or trustworthy. This would manifest as maybe an implicit assumption that someone would be more likely to give up their respirator, give up their life. Finally, there's a catastrophe bias, in which the clinician projects onto the person, the patient, the presumption of more suffering, less quality of life, and more mourning, the need to mourn. Therefore, this will produce less hope for prognosis and less assumptions of resilience, more clinical pessimism, and more likelihood of thinking of giving up. And now when your own doctor is less hopeful, more pessimistic about prognosis and treatment success and survival, and underestimating your own resilience, this is going to have a huge impact which is not captured by any of these abstractions, the philosophical abstractions. So now thinking as a philosopher, I would like to just first start by asking us to think about, when we say evidence-based or scientific or measurable, it doesn't necessarily mean it's moral. These are all moral judgments. Baked into all these calculations are presumptions that are totally moral. So don't presume that when you hear this is a medically necessary or evidence-based calculation that it's somehow neutral. And the examples I gave above should help us see that. But now, what would it mean to really, really consider that all people have equal worth and inherent dignity and have equal access to care? I would like to challenge this on a couple of fronts. So, because the decisions we make not only are about the patients we treat, but the kinds of people we become when we make those decisions. Consider what kind of a nation we would be, what kind of moral injuries we are willing to sustain in making the decisions that we make about who is more valuable, who is dispensable. Is a homeless person really less valuable than a CEO? Is a philosopher or a poet who's not contributing to society as much economically or socially, less valuable than a banker or a politician? So we should be making decisions based on whether treatments are likely to be helpful and the objective clinical state people are in, the likelihood of medical benefit, not who's more worthy of treatment. So I agree with looking at total lives saved. I disagree with looking at life years or long-term survival. In fact, I find a contradiction in this bifurcation of quality of life and long-term survival or life years. So how can you say quality of life shouldn't matter in making decisions, but we're going to care about life years or long-term survival? I mean, it seems like both of those are on the spectrum of some kind of utilitarian thinking. So the first challenge is to think about the fact that one's productivity in a market or ability to contribute to society really should have no impact on one's being more deserving of care. Even if we prioritize the lives of healthcare workers, there's a presumption you hear in the culture that their lives are somehow more valuable. They're not more valuable, right? And I would challenge us to think, are all healthcare workers more deserving of a respirator than all non-healthcare workers? How about the scientists who are studying these questions? How about the politicians leading the administration? How about the scientists studying questions that cause more mortality than COVID, like heart disease? Are they all more worthwhile? Are they all more worthy of a respirator? I think I'm very skeptical of this. And finally, the second challenge is, what would it mean to give a preferential option to the most needy and vulnerable, as opposed to assuming some kind of utility maximization? So if the coronavirus itself is engaging in age discrimination, it's doubling the chance or quadrupling the chance of one dying if one gets it if one's old or disabled. Why would we double the discrimination? If it's more likely to kill the elderly, why shouldn't they get a priority in our caregiving? Why shouldn't the disabled get a priority in our caregiving? Why not prioritize those lives since they're the most vulnerable? And finally, two cultural comments. One, I hear a loss of distinction between killing and letting die. So if we choose to save who we can while mourning those who we cannot save, this is not the same thing as choosing who will live and die. So this distinction that sort of justifies euthanasia and physician-assisted suicide is sort of creeping into the background here. So it's really important for us to realize that decisions to save some people are not choices to kill others. That matters morally and culturally. And then finally, to echo what Michael said, why, all these dilemmas are really not ethical dilemmas, they're unethical dilemmas. So the real ethical dilemma is how to change our social conditions to prevent these tragic choices and situations from emerging and persisting in the first place. We shouldn't fool ourselves into thinking that the optimized utility algorithm is the solution here. It's an unethical, tragic situation. And so we shouldn't romanticize these kinds of solutions, that if we just get the calculus right, we're going to solve this problem. Just like anything that has happened in wartime situations, in the Holocaust, where people had to choose between which of two children to let live. But let's focus on the real issue here, the real ethical issue. Thank you.
Okay, so now we're at the part of the day where we'll have some questions. I already have 2 questions from the Twitter feed, but I'm going to start with a question of my own. And if people have more questions, remember, just post it on the Twitter feed using our hashtag. So the question of my own, and hopefully we can get those other videos up so we can see everybody when they're answering. The question I want to start with is actually two legalistic questions. The first has to do with the definition of disability under the Americans with Disabilities Act and the Rehab Act. And so I'm curious about your views about disparate impact for people whose life years are affected by medical conditions, but who do not qualify as being disabled under the Americans with Disabilities Act and the Rehab Act, and the question of major life activities. So it seems to me many of the things that might affect likelihood of survival will not count as disabilities under the ADA, and how you square whether you think the application of these triage protocols to groups of people who are disabled within the meaning of the Act is different than those outside. So that's one question, and I'll let people jump in a sec. The other question I'm curious about has to do with actually whether the opposition to life years as a metric of allocation extends for you far beyond ventilator triage, in that, for example, lung allocation, which the PIT protocol is based upon, is based heavily on survival. Actually, all the organ allocation protocols are based, at least to some extent, on anticipations of life years. And what's interesting is that that is a protocol that has been more or less, I think, explicitly blessed by HHS in their work. So I'm curious whether your view is, if you're right about ventilators under the ADA and the Rehab Act, that also means that our current organ distribution system is unlawful. So people can jump into one or the other, and then we've got a bunch of questions from the audience after that.
I would say if there's a minimum threshold by which people could agree on life years for organs, leaving it above that threshold would be a wide open space where we wouldn't come down on any particular number.
So, I mean, I'll jump in. I would agree that we actually have thinking to do about organ transplant allocations. And, one of the points that people are making is that it is important to think about not only COVID as exceptional, but to think about it in the context of what we could learn and how we might rethink other areas of our practice. I do want to say something about disability in the first question that Glenn asked. The amendments of the ADA Amendments Act, were designed to extend the definition of disability, or to extend how we construe, how we interpret the definition of disability generously. So that's one point. Don't get sucked into thinking that who qualifies as disabled under current interpretive views of disability in the ADA is very narrow. The second thing I would say is that the ADA prohibits discrimination on the basis of disability. And so there's a question about whether what it focuses on is the definition of disability and who gets to be special that way, or whether it focuses on the question of what is discrimination on the basis of disability. I have, in a bunch of things, interpreted it in the latter way, although there are questions about the extent to which it is a categorical statute, even a very broad one. Michael's thought about that too and might have some things to add on that point.
Well, agreeing with my friend and co-author colleague Leslie, I would also add that regardless of the technical, crisp definition of disability, either under the ADA Amendments Act, or a broad view of the Rehab Act, Glenn's question goes to a very good social policy question, which is, there is a population of individuals who, even if they do not rise to the level of technically being included in the disability category, still have impairments that often mirror some of those disabilities and still are in need of social services, including access to health care. Leslie and I and our late wonderful friend Anita wrote about that in Chicago as it related to employment and accommodations. But the same is true for the healthcare area and for other areas. And as a matter of social policy, it is part of the reason why we've seen this huge inflow over the last 10 years since the 2008 downturn onto the Social Security rolls of individuals who are older, have lost their pensions, have impairments, but whom one side of the political ledger points to as welfare cheats and the other side of the political welfare spectrum points to as individuals requiring insurance and other forms of benefits. That's a big social policy. We can call them people with disabilities and dependencies if that makes it easier to address the cohort.
And I have a thought on the second question, which is that I think it'd be really useful to be clear about what we mean by minimal triage and think about that in the lung allocation context. So I think it'd be useful to differentiate. I thought Omar's comment was really helpful about differentiating maybe shorter term from longer term survival. And I think it's important for the lung allocation protocol. It focuses on shorter term. I think one of the main things it looks at is within, say, a year. Some others look at 5 years. Some of the disability advocacy documents I've seen take a much more limiting position on this. One letter, for instance, says any non-tiny difference in survival probabilities has to be ignored. And so I'd be interested in knowing whether folks here think that we have to ignore differences in survival probabilities itself, because that seems like a much starker distinction that would definitely cause problems for lung allocation if you couldn't, say, differentiate a 10 from a 50% probability of survival. I don't think 10 is a tiny probability, but I think it's something that's worth differentiating and taking into.
So let's hold your thoughts on that last question Govind asked for 1 sec. You can answer in the next round. We have now about 10 questions on the queue, so I want to get through at least a couple of them. The first one is from Professor Dorman. A study from the Syracuse University Learner Center showed people with IDD are more susceptible to COVID-19 due to being sensitive to pneumonia. How does this intersection between devalued disability and health conditions affect your critique?
I mean, I think this underscores the point that Professor Stein and I both made, that you have to look at the background conditions that are causing a scarcity as well as at the scarcity itself. I think one driver of this may be some of the situations that we've been seeing in if people are not able to be in the community who have IDD, that there are these failures in limiting the spread of COVID in some settings where those folks may be especially likely to be.
Anybody else want to jump in?
Yeah, I mean, it's noticeable. You can make a general point that there is a problem about survivability, even just minimal survivability, that background social determinants of health and background conditions are going to be baked in. We're seeing that with race. The intellectual disabilities question raises that question. And I mean, to me, what that says is we really need to be thinking more generally about injustice in our society.
Terrific. So now I've got a pair of questions that I think go together, so I'll ask them both. One is from Phoebe Hong, who's a student fellow at the Petrie-Flom Center. She says, if states are setting guidelines for evidence-based medical judgments for triaging COVID-19 care, how do we account for variability in policies across states, and is that permissible? So that's one question about variability across states. The second is from Carly Zubricki, who's a Klemenko Fellow at the law school. What role is fear of litigation playing in the creation of triage policies? At an operational level, does a more individuated approach like Professor Francis's end up putting the onus of resource allocation on individual practitioners, and is that good? So heterogeneity, fear of litigation, devolution to the bedside. What do you all think?
Well, so I'll start out on that since I was named in that second question. What I see going on at the bedside is application of criteria, not selection of the criteria. So that doesn't really speak to whether we're dealing with fear of liability here, but it speaks to where I think the decision ought to be made. I don't think you can avoid clinical judgment at the bedside. What I think you can do is caution over and over and over again against the biases that have been documented in such application of clinical judgment. On the federalism question, federal anti-discrimination law sets a floor, and states can vary. And I'm actually working on a book right now on federalism and issues in bioethics that is going to be coming out from Oxford in probably about a year, depending on how quickly I get to it. But one of the questions that I think is just enormously important is, to what degree can we tolerate, as a decent society, states that leave vast percentages of their population without health insurance at all? And this is a version of that same question. To what extent can we tolerate variations in justice about a really important decision?
I think it's clearly important that all states comply with whatever the law is. I think it's important to have a clear understanding of law. So one thing that I found really interesting, and I wasn't sure about in Professor Francis's comments, is in terms of the doctrinal state of what the law actually is. I can see the case for critiquing aspects of some of the past case law, but I think it's important that in states making their decisions, they're guided by what the law actually is. And I do think there's actually room for states to legitimately differ on some of these issues. I think Maryland, for instance, did a process of public gathering public views about fairness in their state. I think Minnesota did things like that that were similar. And I could see a case for states to legitimately differ about some of the ways they design their triage policies. This is agreeing with Omar. These aren't sort of decisions just for doctors. These are sort of public decisions. And as long as those decisions comply with federal anti-discrimination law, I think it's legitimate and proper, just as other public health decisions do, for these kind of decisions to be made at the state level and to vary in some ways between states.
I'd like to chime in by saying that in response to some of these questions, that by and large, my opinion is that healthcare providers are trying to do the best they can. They're under enormous stress. They're being absolutely heroic. But some of their decisions are being influenced by clinical biases that Omar and I have written on, and by social biases as well. So when Govid speaks as well about states being able to prioritize, I agree with him to the extent, and he does draw the line at being, contrary to ADA or other discriminatory laws. It's very interesting that when they did it in Oregon many years ago and held it open to public opinion, people with disabilities were so far down on the scale that the Bush 1 administration invalidated it. So we need to be careful about how social biases get included in all these neutral sort of matrices. And going back to our friends, the Dailies, I'd like to ask the question, how many people with disabilities were included in the focus groups, panels, or as researchers in coming up with these numbers? Because I would bet an awful lot amount that you would wind up with a different metric if you included the stakeholders and their perspectives.
So let me add one more point about states varying. States have expertise. The question isn't, can states vary, but on what issues and on what grounds and how much? So we're seeing another example potentially of state variance right now, the governors of the West Coast states and the East Coast states, where they have knowledge of local conditions that is very important, and they have a kind of expertise. I think what Michael's really emphasizing is that there are floors that we think in a society in which we all live together, no state ought to go below.
Excellent. So I'm going to throw another 2 questions out at you. One is from Gabrielle Katz. Gabrielle Katz, where do you see room for the most immediate progress? Should there be more state work while the feds work on this issue? So a little bit connected to the federalism, but this question of what to do tomorrow if you're concerned with this issue. Another is from Amina Serimovic. Are there any reported cases in practice of people with disabilities being denied COVID-19 treatment on the basis of disability? Anybody want to speak to one of those, either reported cases or what should you do today? If you've been inspired by this panel, if this is a pressing issue you should get involved in, what do you say you should do after this panel?
Well, I think it's going to be a little while before we see the reporting of cases, and I hope that we'll see less overt discrimination and exclusion than more. Although now we're starting to see reports from various places, including China, about how people with disabilities, not just ID, have been treated. But as far as a federal or state response, I would note that our wise president has declined to have a czar or an individual who is capable and competent at coordinating responses, coordinate and be capable in coordinating responses. So far his attention, besides lauding himself daily on his press conferences, has been to take away the individual who would oversee the disbursement of the stimulus package, but we don't have a response. So thank goodness we have some very capable, innovative governors, mayors, etc. But unfortunately, they're in competition with each other for scarce resources rather than being able to coordinate together. And that, I think, is costing many, many lives.
So I would say the question about cases, it's really important where we look. So a lot of the things that I would consider serious discrimination are not happening at the point of who gets on the vent. They're happening at the point of who gets testing, who gets transferred, who shows up at the hospital. And there are a lot of reports about very problematic differences in that respect that I think one needs to look at. And if I were going to move forward, I do some disability rights work as a lawyer. I represent people who are the subject of guardianship. I would think very seriously about our policies about nursing homes in the United States, about inspection, about paying staff living wages so they don't have to moonlight in the way they currently moonlight. And there's a lot more to say about that.
I think it'd be really valuable for people to, this is an issue that's going on live right now in hospitals, for governors, for local communities, and for senators. If you think some of these factors should be considered or shouldn't, you should write to them and say that. If you think, with me for instance, that it is important to give consideration to probability of survival in order to save more people, you should say that, because some of the proposals say we should ignore that factor. If you think, I believe with all of us, that we shouldn't consider sort of quality of life determinations, then you should write and say that. I think it's really important to keep clear the question of whether guidelines should include quality of life determinations, which I think we all think they shouldn't, from the question of should we look at probability of survival, should we look at, say, 1-year life expectancy. A lot of senators are signing letters saying things that would imply you shouldn't be allowed to differentiate the pancreatic cancer patient from somebody with a very different disability. And I think if you agree with the view that those patients are different, there's also room for saying that to your senators, to your governor, while differentiating that from quality of life.
Excellent. 2 more questions. One from Daniel Aaron, who's a student fellow at the Petrie-Flom Center, and this is about the relationship of what you've said to age discrimination. If ventilators should not be allocated based on life years, does this logic apply to allocating ventilators to people of different ages? is that age discrimination? And from Charlene Lerner, how do state policies granting immunity to healthcare workers interact and fare under the ADA? So one is age discrimination, one is these immunity statutes that are being passed in some of those states.
So on the straight life years, the answer is yes, it would apply. The question, which is worth a longer discussion than we have time for here, is whether there is an argument that applies in the age context that doesn't apply in the disability context, which is the so-called fair innings argument. That is, whether you've already gotten to play to your last strike in the 9th inning versus so where you are in the life cycle, and whether that's an independent question that ought to give us some reason for saying that age, at least at a particularly advanced stage, can count. I don't favor that view because I think innings are not equal. There are a lot of people who get to older ages who've had horrible innings, and the fair innings argument needs to take that into account, but that's a topic for another day.
I'll say something just quickly about age discrimination, because I think it's really important to understand the difference between the different statutes here. The Age Discrimination Act is very different from the Americans with Disabilities Act. It contains specific exceptions for state and local statutes that consider age. It contains a carve-out that pertains to cases where age is being used as a proxy. I think that there are good reasons for that. I think age is something that is going to be different from disability in terms of being subject to biases. There are ways in which being, say, 75, that's just a fact that you've lived through 75 years of life, in a way that a lot of judgments about disability are going to be more subjective. As to the argument about quote unquote fair innings, I don't prefer to use the fair innings terminology. I don't find it very helpful. But I think the idea of what's called a life cycle principle that folks like Norm Daniels, for instance, at Harvard defend, I think is morally compelling. I think if you look at the Maryland guidelines again, when they did public assessments, a lot of people in the public, including older people, thought, look, it's bad for anyone to die, but there's something especially unjust about somebody losing the rest of their life at, say, 30 versus 80. And I think I see the point about that some people who are older may have lived lives that are very challenging, but I think getting into that would get us into quality of life determinations that I think are exactly what we want to avoid. So I think there is a compelling case for using the sort of life cycle considerations that Norm Daniels and others talk about, and that the Maryland group, Maryland citizens included in their recommendations.
Robin, one response to that is, if you look at the judgments people make, oftentimes people will say that the life of a young child is less tragically lost than a 15-year-old dying. So it's not a linear assessment of innings or years, and they're totally, who knows why that is. There's probably some bias in looking at the very young as well. So I'm suspicious of that.
Yeah, I'm not defending linear assessment. I'm just saying it seems to me like a factor that is legitimate to consider, can be considered without some of the biases we've talked about before, and that people, I think there's a consensus across a range of views that it can be relevant. I'm not specifying how that factor should be considered, or saying it needs to be considered in a linear way.
Yeah, and I was saying that the quality of, that the fair innings argument gains some of its moral appeal from the idea, or from the assumption, that quality of life as people have lived through the life cycle has been roughly similar. I tried out a version of that argument some years ago, and boy, did I get slammed by feminists who pointed out that life cycle analyses may look rather different for people who spent their lives sacrificing for others.
And we also had a second question from our student Charlene, who we hope to celebrate her graduation in a couple of months, on immunity for healthcare workers. And Charlene's referring to things like, for example, the Florida healthcare workers asking for immunity from anything other than criminal negligence and/or intentional acts. My initial reaction to it as someone who's got a degree in 19th century history is that once upon a time we had something called charitable immunity, the idea being that paternalistic, well-intended organizations, often faith-based, who were doing really good work within their communities ought not to have any liability for any resulting harm from the individuals they were taking care of. And we saw very bad results from that, ranging from inadvertent harm to the movement towards institutionalization and so on. So I believe that our healthcare workers are acting in best faith and are doing heroic work, but they ought to still be held to acting under reasonable circumstances. What is reasonable in a COVID pandemic is going to be different than what's reasonable in the day-to-day lives of providing care to individuals.
Excellent. So I think we are almost done, but two more questions, one from the audience, one more from me. The one from the audience is Nurse's Kid 1 is the person who asked this. A question about disclosure. Traditionally, a physician has a fiduciary responsibility to a patient. So in triage, what disclosures become appropriate as to the evidence base for a decision? So that's one question. And then my question, I wanted to end on a slightly more hopeful note, which is to say, imagine we get past the ventilator issue and we're now instead talking about resuming not normal life, but return to work. I'm curious whether you have any views about whether discussions about antibody testing and conditioning access to employment on antibody testing or the like, how that's going to intersect with the Americans with Disabilities Act, the Rehab Act, or other relevant statutes. So thoughts on either of those would be very welcome. And then when you're done, we will wish adieu to our audience.
So I have some thoughts about your second question about antibody testing. I think it's going to be really important to, if this is done, to do it right and to consider the impacts both of doing it and of not doing it. I think one question that people sometimes raise is, what about people who are not yet immune or can't be immune? How we think about the way in which a regime of conditioning some opportunities on testing would affect them. I think it would be valuable to be clear about two different questions. One is how we can support those people effectively and how we can make sure that they have access to jobs that don't put them at risk. And then the second question is whether we need to ignore differences in risk when assigning people to jobs. And I think everybody is going to be protected by disability law, but I don't think disability law is going to require ignoring differences in the risk that someone is placed at themselves or that they may place others at in a specific job. I think the Supreme Court case, Chazabal, I think speaks to that question.
And I would just add a gratuitous comment that while it's important to include people on the basis of disability, protect them against discrimination on the basis of disability, we have an 80-something plus % unemployment rate among people with disabilities as is. So my political comment is, let's get people with disabilities jobs first and then worry about COVID testing.
Yes, and I was suggesting in my thoughts that we are going to need to think seriously about accommodation for people with immune compromised conditions, for example, who may not be able to work safely. But we're also going to have to think about modifications in work structures that might actually turn out to be like curb cuts and beneficial for everyone. I mean, I think we're learning a lot about what we can do with internet connectivity that we never would have imagined even 6 weeks ago.
Excellent. Well, with that, let me thank the panelists and thank all of you who stayed to the end. This will be available for further reviewing in about 1 to 2 weeks with captions. And again, our next event on this topic will be, on COVID, I should say, will be about the ethics of PPE. And I think that'll be of particular interest to some of the medical people, but really to everyone. So thank you again very much, and I wish everybody to stay safe. And thank you again.
Thank you.
Thank you.
Thanks, Glenn. Thanks, everyone else.
Thank you.
Thank you.